Welcome back to the House Healthcare Committee. It's the afternoon, and we have Mike Fisher, a healthcare advocate, and I'm sure you will.
Okay.
So I'm just going to stop right there real quick. Mike will become your best friend and his crew that supports him so well, because he is the voice of consumers, Vermonters, and we can go to him with our issues that constituents have and just other questions, and he has a wealth of knowledge. So, tap into him if you want to understand some of the history that's before, that happened. So now I'm going to turn it over to you.
So, Mike Fisher, healthcare advocate, and Chair Houghton, if it's okay with you, I think the right thing to do is to start with the legal aid portion of our.
Right. I'm sorry. I completely forgot we were doing that.
So
yes.
I'd like to introduce you to Rachel Seelig, who is going to introduce herself a little bit more and tell you a little bit about the organization that the Healthcare Advocate's Office sits in. And then I'll come back. I think
Perfect. Thank you for that. I apologize, Rachel.
Oh, please don't. That's fine. Mike is definitely the famous one between the two.
He is. Yeah, sorry, he is.
So for the record, my name is Rachel Seelig. I'm the director of the Disability Law Project at Vermont Legal Aid. I will also be the attorney for Vermont Legal Aid in the building this session. Some of you who've been here before know Wendy Morgan, who is now our interim executive director. So she's a little busy with that job.
Yeah.
So I just a couple seconds of background about me, and then I'll talk about legal aid. Grew up in Vermont, grew up in the town of Calais nearby. Actually did 4-H with Representative McFawn's daughter, Molly, and we're still good friends. And spent a couple of years after college working for Congressman Welch, then law school, and back to Vermont Legal Aid as quickly as I possibly could be from law school. So I've been with the organization for a little bit more than 10 years now. I started out in our Medicare advocacy project. Then I worked on our state's first medical legal partnership project, which we set up with the UVM community health team. And then I've been with the Disability Law Project since about 2015 and the director for the last year. So that's who I am.
Great. Welcome.
Thank you. So Vermont Legal Aid is the largest single provider of free legal services in the state of Vermont. And we have 11 different projects at this point. And so what I passed out to you was a short description of each of those projects, as well as the name of the person who's in charge of that project and their contact information. I'm going to talk a little bit about what we do, and I want you all to have these people to reach out to for your constituents if you need us, but you can also just find me or Mike, and we will connect your constituent to the right person, because we're a large and complex organization, and it's not always easy to figure out which grant is the best grant to fund the work that folks need.
Let me emphasize that again.
Yes.
Either one of us for anything.
For anything. Yeah.
But just so you know, I do healthcare and Rachel does everything else.
And that's not quite about even. So that's the split. So when people think of legal aid, they tend to think of our poverty law project, right? That's that is one of our projects where we only serve people who are living in poverty, and we do all sorts of things to serve those folks. We do a lot of housing work, eviction defense, protecting people from losing vouchers so that their housing does remain affordable, benefits work, access to Reach Up, 3 Squares, Social Security, unemployment insurance. That's continued to be a significant need in the state. So all those kinds of different issues we do in our poverty law project. And that's probably what people think of most often when they think of legal aid. But we have all these other projects too. So my project, the Disability Law Project, serves people with disabilities who have legal issues because of those disabilities. So we do a lot of discrimination work. We do work around access to special Medicaid services for people with disabilities, especially developmental disabilities and autism. We do work around guardianship, special education, access to justice around discrimination. So it's a pretty broad scope of work that we do having to do with legal issues because of someone's disability. And that's not income restricted. So any Vermonter who has a disability and a legal problem because of that. Sorry, go ahead.
Why don't I jump back in?
Yes.
So I think it's been announced I served in the in the House for 14 years. And those of you who've been around for a little while know that people will call you with concerns.
About anything.
That you have no idea. And, I was always a human service healthcare guy, and someone would call me and say, I'm really worried about aquatic nuisance in the South Lake. And you need your resources of where to turn to, to address people's concerns. And so I think one of the main things that we're here to say is we're a resource for you in serving your constituents. My experience is, I gotta be honest, if I get a person who needs care through the chair of the committee, or if I get them calling us, we're gonna do our very darndest to do the exact same level of care.
Absolutely.
And they do. I mean, I will vouch for the fact that they definitely do.
But I find that the people who reach out through their legislator are a little bit more desperate, a little bit more not knowing where to turn, and a little bit more sort of frustrated with the whole system. And so I think it's sort of it's, to some degree, I think we're saying we want to help you in serving your constituents, and we want your help in reaching the right people in your community who could use our help.
You want me to keep going, Mike?
I actually want to boot you.
You want to boot me. That's fair, because I know you have policy stuff that you want to talk about. I'm going to stick around while Mike does his talk, and happy to answer questions later on. And again, I'm in the building if you ever need to talk to me.
And your contact information.
And my contact information is on this form. Yeah.
So let me ask just one question.
Sure.
This would be for both of you. Would you prefer that if a constituent comes to us, that we give them your phone numbers, or that we go to you and say, we have this constituent issue? I just want to be mindful of the phone numbers and contacts we're giving out to people.
Yeah, I'll speak for myself, and Mike, you can tell me if you feel differently. We would love for that information to come to us from you.
Okay.
And then we can have the right person reach out to the constituent rather than having to send them through a complex intake process to get to the right person. We can try do our best to get to them as quickly as we can.
Okay. So call you with the issue.
Yep.
Okay.
Get the contact
We'll
information.
get the contact information from you, and then we'll call the constituent.
Great.
Yeah, absolutely.
Thank you.
Thank you.
I'm sorry. Representative Pearson, did you have a question?
No, I want to make sure I heard that last thing correctly.
Okay.
Great.
So I also, just while we're transitioning from legal aid to healthcare advocate's office, again, I just want to recognize that there is also some difference in the way the different projects are set up and what they're designed to do. The healthcare advocate's office is a helpline. I mean, we have a helpline. And so, and I want to introduce Emma Zavez, who's here with me today. Emma, boy, I'm going to be disjointed. Emma is our newest hire, and yet one of our older people, because she transitioned from the advocacy team over to the policy team to do a new role that you helped us get last year. And so I kind of wanted to show Emma off.
Absolutely. We're excited you're here.
And say thank you. You helped us get a new position last year, and that was really helpful. And Emma's brand new, or even transitioning still into the role, and that is to help us do a better job on consumer research. Part of the statute is that we help consumers have a stronger voice in healthcare considerations, and so it's not uncommon that a policy table like this goes, gee, what's really going on for Vermonters in this space? And I think, and we can look at the cases people have called us, but I think we need to do a better job of being able to reach out and talk to Vermonters about what's going on.
Great.
I also want to introduce Eliza, say your last name. Rockasader, who is an intern.
Oh, great. Welcome.
All right, boy, I'm never going to get through anything. I want to tell you about a few things that are on the web. I actually want to give this one
On our committee page.
on your committee page. So I have found, sitting in this room in the last couple of days, that there's a few people that like going into the weeds.
Imagine that.
Imagine that. And so this is a cheat sheet that we produce and do our very best to keep up to date. And I think it's a good resource for you to be able to see every state program, every Medicaid program, and its eligibility and who's there to serve. Okay? And so you'll see on the back, there is the federal poverty level and a listing of all programs. And I think I just quit there.
May I just ask a quick question?
Yes.
How does the federal poverty level get updated, if ever?
It gets updated annually, and the answer to that question, boy, it's good that I have Emma with me. She might actually know the answer. It's more complicated.
Right.
Programs update at different times.
Okay.
And so I think you probably mean for the exchange and Emma.
For the exchange, for the advanced premium tax credits, they actually use the 2022.
Okay.
For Medicaid, for the age blind and disabled, and the Medicare savings programs that I think Mike will be talking a little bit about, they're using estimates for 2023 at this point.
Okay.
And I think the official numbers come out soon.
Okay. Thanks.
I also put up on the webpage, your webpage, our last quarterly report. I'm not going to spend any time talking about it, but I thought I should at least put it in front of you. It has more details than most people want to see about the casework,
Right.
about our work. And now let's.
Except the great picture of your team.
Except for the great picture of our team.
Yeah. Which is really cool.
Let's see if I can figure out how to share this presentation. I'm going to just walk through a little bit of what we prepared to talk about today. So here's the Healthcare Advocates team. A not very formal picture of us on top of Snake Mountain not too long ago. And I'm gonna sort of speed through a decent amount of this, but here's what I'm hoping to talk about today. I want to recognize I have put more on this presentation than I will get to, or maybe that I should get to. This is the legislative priorities for the year. What we're hoping to talk to you about this year this is maybe just a teaser to let you know, and you can look at it in your own time, or you can always pull me aside. I'm going to pause and do just a little bit more personal introduction. I love this stuff. I love talking about it. It is indeed my job to be a resource to you, but I'm always happy to spend time talking about your ideas about what we need to do, or talking about giving you my perspective. And I'll do my darndest to say, hey, this is my opinion. Or where I think I know the facts. And so speaking of which, I was in the chair of this committee. I was in the vice chair of this committee when Act 48 was passed. And I was in the chair of this committee for the 3 years afterward. And so your discussion this morning about Act 48 and the principles, a little bit of a flashback.
So basically you're saying, so if anyone wants to talk outside of committee, find me. I'm happy to give you the history.
Or not. It is flashbacking, maybe.
Right, or maybe not.
No, it's good. I mean, some of it's good, it's all good. HCA this is a really important point. I think a lot of people don't know it, but we are not part of the state government. We are not part of an insurance company. I read all of the client feedback, and now and then somebody expresses real frustration with us, and almost every time it's because they think we are an insurance company or the state. We are free, and all you have to be is a Vermonter. And even that we can be a little squishy on. You know, I think somebody has a strong link to Vermont. We're going to do our best to provide support. We've been around since 98. Though the office took a significant turn, we changed a lot in 2011. That same time period when the state was trying to pass, when Act 48 passed, was also the time period where we had a phenomenal failure of a launch of Vermont Health Connect. And that was a time where Vermonters needed as much supports as we could possibly give. And that was a time when the Office of the Healthcare Ombudsman turned into the Office of the Healthcare Advocate, and we increased our staff significantly. And I also think it was a time when the Healthcare Committee recognized that Vermonters needed more protections from this system. So the policy. There's a recognition of our statute, and we are organized into two teams. Everything we've talked about so far today about our office has been the advocacy team, and that is 8 advocates who are on the phone responding to individual Vermonters' any number of complex problems that they're dealing with. In addition to that, we have a policy team. And the policy team is made up of 2 attorneys and a public policy person and a communications person and myself and now Emma. I don't know how to describe you. We have this ominous task of representing Vermonters at any table where healthcare policy is being talked about. So a lot of that is at state government, but it's also advocating, with hospitals to do a better job on free care policies, or with insurance companies, or with anywhere where people will listen to us. We do our best to be there. Yes,
Mike, just a question. Is there a state entity that mirrors or is close to doing what you do? Because after 2 years of listening to all this, I did not realize you weren't part of state government. I just learned that 5 seconds ago. But I didn't know whether there was something that...
Yeah, thank you for the question, because it reminds me of, you had the secretary in front of you yesterday who talked about when you should call the commissioner, when you should call the secretary's office. And I was thinking that, yes, there are parts of state government that are also have the responsibility of responding to Vermonters' individual needs. And so I often ask myself, when should you call the commissioner and when should you call me?
Yeah, that's a good question.
And hey, you're state reps, you get the commissioner, you should call the commissioner. That's sort of an obvious answer. You get the commissioner, you should call the commissioner. But the commissioner's job is a little different than my job, than our job. The commissioners, you call the commissioner and you say, hey, I've got a constituent who says that their income was miscounted. They think they should be eligible for a program, but for some reason, DIVA said no, and they think you're wrong. So the commissioner's job is to make sure they followed the rules. Maybe they did, maybe they didn't. And then you get a good outcome or you don't get a good outcome for your constituent. Our job is to help the person get care.
Yeah.
So maybe they did count the income right, but maybe they made another mistake, or maybe there's another program available to the person. And so I guess I would always encourage you to do both. Anyway, that's not exactly the question you asked, but.
No, I get it. And it only was prompted by the fact that that I saw that you weren't part of state government, and it just came to mind.
Yeah.
Thank you.
Let me just say, yeah.
Can I just say, kind of the philosophy I use is when I don't know who to call and it involves a constituent, I call.
Oh, absolutely. Oh, I a whole lot of.
Because even if it's not them.
I don't even think twice.
Yeah.
Yeah, we do our best to be as responsive as we can.
Yeah.
And I think it reminds me that we solve a lot of people's problems. We're also a front row seat to a lot of problems that are not solvable by us, that where the system is not working or is not right to meet people's needs. The hardest calls are the ones where you have to say, this really stinks. It's really bad for you and your family. And I'm sorry, DEVA or Blue Cross or whoever followed the rules.
But can I add, and maybe this isn't true, but I would think those conversations pile up like groupings, right? And that informs your advocacy and policy work.
Yeah, so thanks. That's almost taking the words right out of my mouth. I think if you look around the country, you'll find great shops that are set up to do individual advocacy, and you'll find great shops that are set up to do public policy in healthcare. But it's fairly unusual to see both of them in one shop. And so we are at our best when the two teams inform each other. The day-to-day work of the two teams is entirely different. But there's something that happens in healthcare policy that happens to healthcare policy wonks, and I don't exactly understand it, but it's easy for healthcare policy wonks, welcome to the club, to become separated, to separate the issues from how it really plays out for people. It's somehow easy. And it's all so technical and so, we lose touch with how it affects people. The great thing about my office and the way it's set up is I've got this group of people who tap me on the shoulder every day and say, this is how it's hurting people. Look at this. This is hurting people in this way. So I think it's partly my job to bring that voice here. All right, I was going to play a little game.
Sure.
Okay.
Need excitement.
And go postprandial.
And then I can't. So these are a couple of case examples that come out of real cases. Marika is a recent college graduate. She's currently on Medicaid. She started a new job where she'll be making $33,975. I did the math. That turns out to be 250% of the federal poverty level per year. She has an offer of insurance from her employer. She wants to know what she should do. And she calls her office. Any ideas what she?
So the question is, the advice from my advice would be call. You're saying once they call you. Okay.
That's my advice for everything. Anybody asks me any question, even if it's not healthcare.
Right. Oh my God. Sorry, Daisy. I cut Daisy off. Sorry.
I'm gonna.
Hold on. Wait, I cut
sorry.
Daisy off, didn't I?
That's what I said. I said call Mike Fisher.
Oh, you did.
You trained us well. It was impossible.
I would say call Mike Fisher, and I'm assuming that you would go over her income with her, find out what she might qualify for. I'm suspecting she's going to end up on Vermont Health Connect.
Joe, did you ever?
I was curious, was she previously on Medicaid just due to financial, is there anything else going on with her?
She's on Medicaid.
Okay, great. Okay, so.
Can I add something? You said she's a recent college grad. The other thing I'm going to say is call your parents. Get back down there. You got to 26.
The advice is that she's over income for Medicaid, but because of the public health emergency, she can stay on the benefit until she gets a closure notice.
Right.
You know that, Elise. And so we continue to be in this place where Medicaid is not doing redeterminations, and that will change. I think we now know April 1st.
Oh, really?
Does everyone understand what redeterminations is? Maybe we should start there just for,
So-
I don't want to go too far off from your presentation, but just.
No, this is all good. We'll get as far into this as we can.
Okay.
It's all good. In regular times, non-pandemic times, everybody gets redetermined for Medicaid once a year. That is, are you still income? Are you still eligible? Essentially. And so because of the public health emergency, the Fed said, here's a bunch of extra money, 6% addition to our FMAP, I think it is, and you can't close anybody. And that has existed and been extended on a 3-month basis for a long time, and that will, and Congress recently passed, I can't remember what the name of the, Congress recently changed that to say date certain it's going to end. And that means starting April 1st or thereabouts when Medicaid gets their act together, Medicaid has the job of moving this huge group of people through the redetermination process, and it's going to take them 12 to 14 months to do. And you'll get constituent calls about it.
And we will have Diva in to talk about how they're planning to do that.
Yeah. It's a big task. I feel for them.
I do too.
In part because nobody's used to doing it. And so there's this whole set of people out there on Medicaid, many of whom are just as eligible as ever, but they haven't been giving updates about their addresses. And I think we have real concerns about whether people will be reachable. Am I missing anything, Emma? All right, let's try another one. So Alicia and David make, this is a crazy one. I can't believe this one. Alicia and David make $86,000 a year. Alicia has an offer of health insurance through her employer. Alicia's coverage for herself only costs 6% of her income, but health insurance for her whole family costs 17% of the household's income. Can Alicia's family sign up for Vermont Health Connect with financial help? And I'm just going to answer. This is otherwise known as the family glitch.
Family glitch.
And it has been a problem.
I was going to say yes, because the feds just fixed it, didn't they?
You get
Just recently.
I don't know that everyone knows what the family glitch is. Right.
So to some degree, you kind of don't have to know anymore because it's fixed. But it was a problem with the Affordable Care Act for since 2014 or whenever we actually got it going. That kept a whole set of Vermonters out of the financial supports that they really needed to buy health insurance. And finally,
What's the fix? I don't know that I know.
the technical fix is more detailed than I think I should go into, but we are now able to help people, family members, get access to health coverage through Vermont Health Connect. I'm going to turn to you again. What am I missing?
Oh, I think that's, yeah, I mean, I think before they would only look at that 6% and only run the calculation for the individual who is employed, even if they had lots of family members who needed healthcare. Now they run 2 calculations. The second calculation is for if you're putting all your family members on. So that's why they see the 17% now and they say, oh, that's not affordable. That's way over the Affordable Care Act's affordability limit.
And Emma, it strikes me that I should have you say your name.
Emma Zavitz.
is in part for the record, so that people know how to associate your voice.
Okay.
Let me ask, is there an upper limit of what could be considered affordable? Is it 10%?
Yeah.
Yes.
I believe it's 9 point
9,
something right
yeah.
now.
9.3 maybe or something. Yeah.
So, in this example, if it's 9%, the other 8% is paid for by who?
But so this is coverage for premiums, and it is through a federal tax credit. The feds.
The
So-
feds.
And correct me if I'm wrong, Mike. So the scenario is that if you had insurance available through your employer,
Yeah.
you could not buy off the exchange. But because now they're doing this different calculation and they deem 17% way above affordability, that couple could now go to the exchange and buy their health insurance from there with financial support through the subsidies.
Which will bring it down to
Okay,
below 9%.
how much do they support it? I mean, all of it, not all of it?
Where it's different income levels.
And it depends what plan.
A complicated answer.
Yeah.
Okay, all right, okay, but they get help.
Yeah. They get help like other people would get.
So when this person, okay, let's follow it through to the end. When this person gets their insurance, it's not through the employer anymore.
Correct.
Yeah,
Correct.
so Alicia is the employee in the situation. Alicia, with a 6%, she would still get her insurance through her employer because it's affordable to buy an individual plan for just her. But her husband and her children, they would go through Vermont Health Connect and they would get advanced premium tax credits.
Okay, so they would have two separate
They would,
insurances.
they would.
Not ideal.
In the past, you could go on to Vermont Health Connect, but you couldn't get the financial help, so it was way too expensive.
Okay, so, but the primary employee couldn't go there, just the
family
spouse and the rest of the family. Okay, all right.
Wouldn't the children be qualified for Dr. Dinosaur?
I think in this example, they are actually, based on their income, yes.
86,000, you're right. You're right. Alicia, are you listening? We found an error. Okay, we'll do one more. All right, Cecilia is in the United States
It's the bottom, sorry, it's the bottom bullet, advice. You did say Dr. Dinosaur.
Oh, look, she got it.
Yeah,
All right.
yeah, it's there.
Cecilia is in the United States on a work visa in H-2A status. She makes $3,000 a month. She recently found out that she's pregnant and wants to know more about her insurance options. Can she sign up for Dr. Dinosaur?
Absolutely.
So, I sort of thought that we would, that the bill you guys passed last year would confuse the answer to this one, but you got it. She has a lawful immigration status, and so she could always sign up for Dr. Dinosaur. The thing that your committee did 2 years ago
Yeah.
was in a new program called the Immigrant Health Insurance Plan, which now allows us to say to all Vermonters, all Vermont children and pregnant women, that if they're Medicaid eligible, they can get coverage without regard to immigration status. So now even people who are have no legal status, who are children or pregnancies, can get coverage.
Does Dr. Dinosaur have co-pays? Like, do you have to pay for that? How does that work? And that may be a doubt. I'm just, yes or no?
Yes, they're very low, they're
Oh, okay,
$1
thank
to
you.
$3 usually.
There's copays for the prescription drugs.
For prescriptions, I think for outpatient care and for hospitalization, but they're all in that 1 to 3 range.
Yeah.
Thank you.
So that's who we are. And I think the other sort of intent of that was to say, this stuff's crazy complicated for people. There's just no way that they can figure it all out. Since I referenced, in New York, in a bigger state, the advocates, we would have a team of advocates who are doing Medicaid, and a team of advocates that are doing Medicare, and a team of advocates that are doing commercial, if that was covered. Whereas here in Vermont, with our 8 advocates, we asked them to do all of it. And it's a big lift. So I think maybe the right thing to do is, Madam Chair, what would you like me to do? I've got 5 minutes left, and I.
All right, let's stop maybe and see if there's questions.
Mm-hmm.
And we can go a little bit. I mean, we've had a lot of breaks today, so if we have to go a little bit longer, that's fine. Are there questions? I think we've been pretty interactive up to this point.
I don't have a question, but I do have a comment. Your office is an office that I did not know existed 3 years ago. And I have worked in healthcare my whole life. And I just wanted to say, to your point about advocacy and policy, last year, a very simple problem of patient assistance programs at 14 different hospitals. And it was in your advocacy that this issue was popping up, and it was in your policy that you then advocated to us to make that change. And I mean, I know you worked very hard on it, but it was an easy lift, frankly. And that is a very simple thing that makes Vermonters' lives better. So.
Can I ask a question and follow up? Because that was amazing. Did that get implemented?
So part of the behind the scenes work, I do have to say, in response to Representative Black, it was not an easy lift from my perspective. It was a tremendous amount of work over a number of years. But at the end of the day, it got delivered to you in a package that could move. That was great. That was a success. Part of the negotiation with the hospital community was to postpone the implementation date in order to get some stronger supports. And so it is not going into effect until July 24.
Whoa, bummer.
So we're on our way to a system-wide approach to patient financial assistance programs across Vermont that will solve a lot of problems, and actually already are, because we're calling up hospitals and saying, hey, you're going to have to change this. Why don't you change it now? And many hospitals are.
Good. Joe?
I just wanted to follow up on Representative Black's question, because I too did not know about the Office of the Healthcare Advocate until I started campaigning and had some questions about healthcare, and someone I was talking to said, call Mike Fisher. And so I guess my question is, what, in your view, either that we can help with as individuals or could help with as a committee in order for more Vermonters to know about the amazing services that you provide? Because I've certainly needed those services and didn't know about them. I know others who've needed those services and didn't know about them. So how can we get the word out?
Yeah. So I got to admit, so you guys are absolutely right. People ask me often, like, how many people are dealing with this problem or that problem? And I always have to say, hey, the Healthcare Advocate's Office provides a canary in the coal mine, we get to sort of have a concept of what's going wrong in our healthcare system. But I always have to say, of the universe of people with this problem or that one, how many know to call us is tiny. And our 8 advocates are busy. Yeah. For instance, how many people are turned away from the pharmacy counter today without their meds because something is amiss? You ask your pharmacist, you're here, you ask any pharmacist how often that happens, and they'll say every day. And hey, pharmacists solve a lot of problems for people. I'm talking about the ones they can't solve. Or, hey, I thought that was going to cost me $3. How come it cost me $65? I think we need to do a better job of getting the word out, and I can't handle it if we really did. I mean, thank you very much last year for increasing our funding. I'm not asking for more funding for the HCA this year. Legal aid is. So it cuts all ways. But generally, having said all that, we are always looking for ways to reach people better and open to ideas.
Representative Cordes.
I've been really appreciative of the information that you send us that we can use to disseminate through our legislative front porch forum route that I get a lot of response back from constituents that way. Trying not to overload you.
Well, I'm trying not to overload you, but legislators are a good way to get the word out.
And it's helpful to have it pre-written for us.
Yeah, for sure.
Representative Bowman.
I'm just wondering if pharmacists know about if that's one little sort of function. Do they say, here, call the helpline? Because I know that there are people who called, they're standing in line and get it fixed at that moment.
We worked hard on the creation of a referral system, a soft handoff system with the Kinney's, and actually worked quite well for a while. And we were getting good cases through it. But then the pandemic happened in part, and also I would say it needed more love than we could give it. Every pharmacy, the turnover in staff at pharmacies is such, and that, in order, and it was a mistake of ours, I think, to try and do it in 29 stores. We should have tried to do it in 3 or 5. The program is still officially there, though I think it's, we don't get many cases from it now. It's always on my mind that it needs to be woken back up. But it would take a decent amount of effort from us to keep it going. And I think it's the right thing to do, by the way. People call us in an emergency because they got a bill from care they got over a year ago sometimes, often, and it is an emergency for them. And we try and be as responsive as we can to them. People also call us because their provider said they need medication tonight and they can't get it today, and they can't get it. And so we do have urgent cases.
Emma?
You done?
Okay. Anyone else? All right, is there more you want to cover?
So I'm just going to say, we hope to get on the wall this year, a bill to expand IHIP, the Immigrant Health Insurance Plan, to adults. I'm not going to talk much more than that, but that's a topic that we hope to bring back up. And then I think this next slide is as far as I will go, and I think this is intended to just show a problem. On the left side of the bar is the system of supports that we have for lower income people who are under 65 and not disabled. And on the right side of the bar is for people who are over 65, who are 65 and older and disabled. Birthday, you're now 65, you just lost access to care. And I think there's 100 details behind this slide. It's a major policy area that honestly, healthcare committees pretty much never touch because everybody thinks, oh, they're all good, they've got Medicare. But there are state options that we think are appropriate to look at, and you will be hearing our voice in that space.
Good, I say good, thank you.
Good. Thank you. Thank you, Rachel. Thank you, Emma.
Thank you.
Thank you.
Eliza,
thank you.
and the next number of slides in this presentation, which I'm not going to do, go into more detail on.
Okay. Right, we'll have you back, I'm sure. And like I said, Mike's in the room a lot. Rachel's around, so if you have questions, don't hesitate to pull them aside. So great. So we are on break until 2, where we start going over the reports that are part of what we have asked